So let's try to understand autoimmune disorders. So before understanding autoimmune disorders, we understand what is primary immunodeficiency, we understand what is hypersensitivity, we understand the basic of autoimmunity, we understand what is positive selection, what is negative selection. I hope we understand that, right? So let's start with it. And what causes autoimmune disorders? Well, any overactive immune system or loss of self tolerance. I think we understand what is self tolerance. Self tolerance is that when these precursor T cells, they go via positive selection and negative selection, and then they rearrange their genes, and then they pass through positive selection and they pass through negative selection in the thymus, and then we get something called as mature CD4 positive and CD8 positive, or something called as double positive CD cells, right? So this is the idea of self tolerance, right? So self tolerance is that when your immunity is able to tolerate its own tissue. So that's the idea of self tolerance. Overactive is that when you have any sort of hypersensitivity disorder, type 1, type 2, type 3, type 4, or type 5, all right? What is the epidemiology of autoimmune? 1% of your population, mostly in women, affect affects women affects the women of age, childbearing age. Why? Because they have high levels of estrogen, and that estrogen can actually decrease, can mess with apoptosis of these bad CD4 or CD8 cells. All right, so estrogen can cause some problems in apoptosis. So most autoimmune disorders are associated with other autoimmune diseases. So right, what is the etiology? Well, the etiology is environmental factors, environmental triggers, genetical susceptibility. What is genetical susceptibility? It means that twins, if we have twins, one of the twin, like if we have maybe Sam and Dam, right? So Sam will be healthy and Dam will be not so healthy. Dam will have some sort of autoimmune disorders. It happens. We see this happening, right? Other thing is that there is something called HLA subtype. Now, what is HLA subtype? NPTPN22. What is it? So when we try to like talk about genetic susceptibility, we should understand that some genes are more prone or more resistant to certain diseases, right? Especially autoimmune ones. Okay, so these genes mainly affect how the immune system recognizes self or non-self antigens, right? So MHC, what is MHC here? MHC is major histo means histocellular compatibility complex. Okay, so if this MHC is messed up, right? So on the chromosome number 6, on the short arm, not on the Q arm, short arm is P and long arm is Q. So on the short arm at the chromosome number 6, the address is 21. Okay, 6p21. Now at this location, the function is that at this location, the gene encodes self surface proteins that present antigen to the T cell. Okay, the MHC one. Now we have two types of it, right? The CD8 and CD4, right? So for CD4 type, we have class 2 genetic, this HLA, when I'm talking about types, I'm talking about MHC, right? So MHC class 2 presents the antigen for CD4, yes, and MHC class 1 presents the antigen to CD8, right? Okay, so what happens is that HLA subtypes and diseases can be, can be different. How? So each person inherit one set of MHC genes, okay? Each parent, okay? So each parent has one type of MHC gene, okay? So this is called MHC haplotype, okay? Not diplotype, it's haplotype. Haplo means singular. So MHC haplotype, so you get one haplotype from your parent, right? From your mom, and one haplotype from your dad, right? So you get this one and one, and then we get a combination of these, haplotypes, and then this combination determines our immune recognition landscape. This combination determines our immune recognition spectrum, how vast our immune system can recognize, right? So we have this HLA subtypes, right? Now your HLA subtype determines which peptide your immune system can or cannot tolerate, okay, influencing your autoimmunity risk, okay. So there is something called HLA-B27. Now this is a class 1, and the associated risk are arthritis, okay. So there are other HLA subtype as well, like D3, DR3, like DR4, DQ2, D. So these are like just class 1, class 2. Again, when we are talking about class, we're talking about CD8 or CD4 positive. Okay. So this is the thing. Other thing is that there's a gene named PTPN22, right? N22. Now the full form is protein tyrosine phosphatase non-reactor type 22. Okay. The function is the function of this gene is to negatively regulate T cell activation. Okay, it stops the T cell regulation. Now if we get any sort of mutation here, there will be overreactive T cells because it negatively inhibits T cell production, right? So again, if we have some sort of T cell, mediated like cytotoxic type 3, type 3 hypersensitivity. So what happens is that we have some sort of mutation at this address, okay? And when we have this mutation, we will have cytotoxic mediated hypersensitivity, and then we will have something called as type 1 diabetes where the beta cells are damaged, or Rh rheumatoid, or SLE, or Hashimoto thyroiditis, right? So that's the P2P HLA. I'm just trying to teach, not teach, learn myself. So let's talk about systemic lupus. Systemic lupus, cool name by the way. So what happens in lupus? And what happens in lupus is that lupus is a systemic autoimmune disease in which antibodies can cause type 2 cytotoxic mediated antibody bind, right? Cytotoxic, okay? Antibody bind and kill cells, okay? Or type 3. I hope we remember this. So it's either it's like antibody against cell surface, this one, or it's immune complex mediated, this one, type 2 or type 3. SLE can happen because of type 2 and type 3, okay? That's the concept. And what happens is that you have some sort of damage which is happening because of some UV rays, So let's see what I have written here. So what in systemic lupus, what happens is antigen antibody complex happens, right? What happens is that damaged cells from the UV light makes apoptotic debris, right? Debris is that the things left over after apoptosis, right? And then this debris is taken up, is cleared by macrophages. Then if your macrophages have some sort of mutation, or if you have some sort of like problems in your macrophages, you'll have poor clearance, and then this poor clearance will lead to B cell recognizing this debris, and this B cell will take this debris and will make some antibody against this debris. So this debris is actually our own cell, our own antigen, right? And B cells make antibodies against it. So antibodies will be made via the toll-like receptors. Do you know what is toll-like receptors? Wait, let me clear that, because I want you guys to really understand that what is toll-like receptors, okay? Acute inflammation, free radical, toll-like receptors, wait, cell death, ischemia, wait. So I want to just, okay, maybe I want to be able to find it. Yeah, where it is. Okay, here it is. TLR, how? Toll-like receptors are the receptors that are present on the immune cells, right? So they are on the innate system. They recognize something called as PAMP and DAMP, right? And they actually recognize the pattern, and they actually call the macrophages, okay? They call them, hey, we have some problem here. Come over here, right? They recognize these, these markers that are present on pathogens, right? For example, PAMP, that is pathogen associated molecule pattern, or DAMP, damage associated molecule pattern. Example, CD14, aka TLR4 is a TLR, right? Toll-like receptor on macrophage that recognize liposaccharides, LPS, which is shared by gram-negative bacteria. So these receptors, they call the macrophages like, okay, I recognize something is wrong. You guys have some messed up antigens. Okay, you need to clear that. We need to make some antibodies against it, right? So toll-like recognize calls B cell, and B cell immune response starts, and then the antigens and antibody complex is made. It's called type 3, and then this complex, it goes to this tissue and it starts depositing at the tissue, at the site of tissue. So early complement system needed to remove the debris body is ineffective, right? And why it's ineffective? Because we may have some deficiency from C5 to C9, right? If we have some sort of deficiency from C5 to C9, it is an increased risk of Neisseria, because Neisseria it's like sort of a opportunistic infection, right? So we have deficiency in complement. We have deficiency in complement leads to bad clearing, poor clearance of this debris, and this will lead to type 3 antigen. So if deficiency of C1q, C4 and C2 complement, we can it can lead to SLE. And once this complex is made, this antigen antibody complex deposits as the tissue complement system is activated. Now this complement system goes and attacks our own body, and then we have something called as there will be lower levels of CH50, C3 and C4. Now these are complement components that are used, right? Because so this is like a good diagnostic, you can check it. You can check in the serum the levels of CH50, C3 and C4, because we are just using the complement system to deal to deal with the antigen antibody complex. So I hope we understand this, the basic concept of SLE. Okay. Let's read about a little bit about clinical features of lupus. So lupus, it's a cool name. Okay. So lupus, why it was named lupus? Because I think it was because of a rash, right? It was because of a discoid rash, right? Now there's a discoid rash, and what happens here that this discoid rash actually looks like a bite from wolf, and because it looked like a bite from the wolf, they started calling the disease called lupus, because lupus means like a group of wolves, right? So because that's the naming of this disease. So we have something called a malar butterfly rash. Here you can see this butterfly rash upon exposure to sunlight. It's a classic sign. Diffuse proliferative glomerulonephritis. Itis is not otic. If it was otic, it's like protein leak, but here we'll have hematuria in the urine. What can happen is renal damage can also happen, and mostly these two reasons are the cause of death in SLE, right, in lupus. And after, what happens is that this cause of death, this renal damage, can be nephrotic or nephritic, right? Nephritic or nephrotic. And basically, if there is nephrotic or nephritic damage, it means there is some membranous nephropathy, right, happening. That's why we have this renal damage. Other thing that can happen is pleuritis, pericarditis, myocarditis, endocarditis. Basically, itis of the serosa is happening, so we can say that it's a serosal inflammation, itis. Other very, very, very cool thing that happens is called Libman-Sachs endocarditis. It means there is some vegetative growth. Vegetative growth is like this. You will see it. Just Google the image vegetation on the walls. So you will see vegetation on both sides of the wall. That's one of the very key features in lupus. So that's how I remember, like, Libman and lupus. It's like same thing, right? So that's the thing. Okay, am I recording or what? I hope I am. Then we have something called as we are already talked about Libman. Let's talk about antibodies against the blood, right? It's like RBC are the target of this antibodies, right? And this results in hemolytic anemia, results in thrombocytopenia, right? And leukopenia, right? And we know that this is a type 2 hypersensitivity because we have antibodies, right? Antibodies against the cell surface, right? So it's cytotoxic. It's like antibodies to the cell surface, right? We have complement system attacking our own RBCs. That's why we have this RBC anemia, right? Okay. Other thing is that we have infection due to loss of immune system, right? Because why it's happening? Because we have these these complexes made against our own system. So we have loss of immune. Other thing is CNS psychosis, right, due to inflammation of CNS, because we understand why the inflammation is happening. Increased complement system, right? Okay, CNS psychosis. Fever, weight loss. Fever is a sign of inflammation. We know that it's a sign of bradykinin, right? It's a sign of E2, okay? E2, fever, pain, E2, okay? Okay, arthritis, very seen. Discoid rash, that's why the name lupus. It's oral and nasopharyngeal ulcers also seen. Raynaud phenomena, it's non-specific to the lupus, right? We see Raynaud phenomena in a lot of autoimmune conditions, so it's not very specific for lupus. I'm not trying to like go inside deep into Raynaud's, because okay, let's try to understand what happens. Is that this Raynaud is like just really high vasoconstriction response happening in small arteries, right? And usually it happens in small arteries, means usually it happens in fingers and toes, right? And it's like triggered by some sort of stress, right? And what happens is that the blood flow on these extremities is very much reduced and leading to color changes, right? Leading to pain and like numbness, leading to bluishness at these extremities, okay? So this Raynaud phenomena can happen, there can be cyanosis, it can be blue, it can be red due to, hyper perfusion, and it can be paler, that is white. And this paler white is happening because of a vasospasm, right? And like it's like the first stage of ischemia. And if the ischemia continues, we will have something called cyanosis, right? And what is cyanosis? Cyanosis is just bluish color that is happening because of the stagnant, deoxygenated blood stuck in the capillaries and venules, right? So the step-by-step, mechanism I don't want to explain, because I hope you understand that what's happening here, right? And it's like Raynaud phenomena. It can be because of a lot of conditions, right? And one thing that is amazing about Raynaud phenomena is like your systemic. It's a systemic attack, right? Your vessels are getting attacked. So if you see Raynaud phenomena, primarily, I don't know what's the reason, but usually it's because of a secondary reason, right? Okay, so that was Raynaud phenomena. If the patient with lupus avoid renal failure, they will have something called as coronary atherosclerosis that can happen at later stage of the disease, right? Okay, describe Liebman sac endocarditis. Mostly endocarditis happen only at the one side of the wall, up or down, right? If it happens on the both side wall, it's called Liebman sac endocarditis. It's the characteristic of lupus. How do we diagnose lupus? We have something called as ANA, anti-nuclear antibodies. So antibodies against our own DNA, okay? They are very sensitive. These are sensitive, okay? These are not specific. Sensitive means they can be present in other conditions, other autoimmune condition as well. They are used for screening. Other thing is that we have something called as anti-double-stranded DNA antibodies. These are very specific in lupus, right? So these are like very specific. You gotta check them out, and once you see them in the serum, we can see, okay, maybe this guy is going through lupus. Okay. Let's talk about the 3 common drugs that can cause lupus. So the mechanism of drug here is that these drugs are actually they attack our DNA, right? That's the overall mechanism. So 3 common drugs that can cause lupus. How do we diagnose and how do we treat it? The treat is just stop using this drug. That's the remission of the disease. So what are these drugs? This drug is hydralazine, prokinamide, and ionazide, right? So this ionazide, it's an antibiotic we give in TB. This hydralazine, it messes up with the HTN, and this prokinamide, we usually give this in antiarrhythmic. So these, all 3 drugs, all 3 of them, they go and mess with something called as histones. Now, our DNA is made up of histones, right? And once we have these anti-histone antibodies that are specific drug induced, right? And then we have these anti-histone antibodies, and just stop using this drug and you will not have these anti-histone antibodies. So what is phospholipid syndrome? it's a new syndrome, I think. Sorry, it's not a new syndrome, it's a syndrome under SLE. And what happens here is that phospholipid, we have something, our our body has cells, right? And these cells have like layers, right? And these layers are made up of phospholipid, right? So what happens is that antiphospholipid syndrome, what happens? Antibodies are made against the protein bound to phospholipid, right? Phospholipids, what are phospholipids? So what is phospholipid? First of all, let's try to understand it, how the pathophysiology, how the physiology is happening, right? Let's try to understand it step by step. The first step is that antibodies are made against it, right? Now, these antibodies do not directly go against the phospholipids, right? They go against the protein that's binding with the phospholipid on the membrane, right? Our membrane is made up of phospholipids, right? So these proteins are like beta 2 glycoprotein, right? uh, Prothrombin, cardiolipin. These are like, these are proteins, right? So these phospholipid antibodies are made against the protein that binds to the phospholipid, right? We are not right away making antibodies against the phospholipid. We are making the antibodies against the protein that can bind to phospholipids. Okay. Now we have, because of this syndrome, we have anticardiolipin, right? Antibodies. These anticardiolipin leptin antibody, they give false positive for syphilis test, because in syphilis these antibodies are made as well, so you can get confused. Other thing is that lupus anticoagulant antibodies give falsely elevated in PTD lab studies, right? And but the study makes it patient hypercoagulable. Okay, so hypercoagulable, right? So let's talk about a little bit about hypercoagulability. When we are talking about hypercoagulability, like, your body is trying to make coagulation happen a lot. What's coagulation happening is like insoluble fibrinogen converts into, okay, soluble fibrinogen converts into insoluble fibrins. I tell this every time. Every time it's a okay, I'm a little sick, I think. Okay, you understand this conversion of insoluble into, soluble into insoluble, right? Okay, so hypercoagulability, stroke, DVT, hepatic vein thrombosis, placenta thrombosis, loss to pregnancy loss. Okay, so that is antiphospholipid syndrome. Okay, so one of the treatment for lupus is just avoid sunlight, start on glucocorticoid for flares, and start on immunosuppressant, right? Because our complement system is acting up. Again, let's talk about Sjogren syndrome. So this syndrome called Sjogren, or I don't know how to spell this, but Sjogren syndrome or Sjogren syndrome. It's a type 4 autoimmune destruction of lacrimal and salivary glands, right? You can't cry, you can't make saliva. You can't, I mean, you can, but it's gonna be tough. So type 4, we know it's a lymphocyte mediated, right? Let's go back to our types of hypersensitivity. Type 4 is delayed T cells, right? So imagine if you don't have any T cells, right? No Th1, no conversion of class, no class switching is gonna happen. You're gonna just keep making IgM and Ig, just IgM will be there, and no CD8, So imagine we don't have these, right? So if no delayed T cell mediated hypersensitivity, if you don't have that, what's gonna happen is that these will go and they will attack lacrimal and salivary glands, right? And it will result in fibrosis, right? Fibrosis, what is fibrosis? Is just collection of collagen. Okay, now if there is collection of collagen at the sites of these damaged places called lacrimal and salivary, you will have something called as dry eyes, dry mouth, recurrent dental caries, because bacteria accumulates as the teeth are not washed by the salivary glands, right? In older women, parotid, the salivary shit, parotids may be enlarged due to fibrosis because collagen is getting deposited there again and again. You can't chew crackers and there is dirt in my eyes. That's a lacrimal mediated. There will be complaints of I can't chew crackers, and because there is no saliva and there is dirt because eyes cannot be clean due to lymphocyte mediated autoimmune attack on your salivary glands. Okay, how do you diagnose this Sjogren syndrome? How do we diagnose this? We need to the So we need to confirm two out of these three things. What are these three things? First is presence of ANA. So I told you already, presence of ANA is a very sensitive thing. It's a sensitive. It's not specific for lupus. For lupus, we need anti-double stranded DNA antibodies. Okay, but presence of ANA is a sign of autoimmune disorders, right? So ANA is there. Other thing is presence of anti-ribonuclear protein antibodies. So this is very specific for Sjogren syndrome. Okay, it's very specific. Anti-SSA and anti-SSB. So there are two type of anti-ribonuclear antibodies, A and B. A and B, right? What happens is that this anti-SSA and anti-SSB, they can cross placenta. Once they cross the placenta, they go to, they go and make something called as neonatal lupus. Child will have mucus, and then this lupus will result in congenital heart block of the neonate. So Sjogren A, syndrome A and syndrome B. A makes SSA and syndrome B makes SSB. It's not so, tough. Other thing we can do is we can perform something on a biopsy of lips, and once we do biopsy of lips, we can see, something called as lymphocytic silodentitis, and what's really happening here is that if lymphocytes are attacking salivary glands, you will see that in the biopsy of the lips. Okay, what I have written here is that we don't want to exclude sarcoidosis, amyloidosis, because both of them can give dry eyes and dry mouth, right? So both of them can be, both of them, sarcoidosis and amyloidosis, can give dry out, and because essentially there is a deposition of fibrosis, right? Deposit. So any deposition can be, so these, what I'm trying to say is sarcoidosis and amyloidosis are both the result of this type 4 autoimmune destruction. Okay, so either there can be sarcoidosis or amyloidosis or some cause of fibrosis or some maybe deposit of collagen, right? So that's what's happening. So I hope we understand this Sjogren syndrome. It's not so tough syndrome. We try to do biopsy of lips to see any accumulation of lymphocytic silodentitis, and that's the concept. Other condition that can be associated with Sjogren syndrome is that like rheumatoid arthritis, that can be also seen because Rh factor can also be seen in this syndrome. High risk for B lymphoma, there is very high here, or unilateral enlargement of parotid gland. Now this enlargement happens because of the fibrosis, the collection of collagen, and this happens late in the disease and is indicated of B cell lymphoma. Okay. Let's talk about scleroderma, thick skin. Its immune reaction against some endothelial or mesenchyme self-antigen. It results in increased endothelial and less nitric oxide, increased TGF beta. So TGF beta is opposite of TGF gamma, okay, and increase in platelet-derived growth factors. Okay, so what is scleroderma? It's just the thickening of skin, and it happens because of an autoimmune tissue damage mediation, and with the activation of fibroblast plus deposition of collagen cause fibrosis that can thicken the tissue, and it also makes it tight and less mobile, right? So scleroderma can be of two types: limited and diffuse. Diffuse is just, we'll talk about what is crest, what is limited, and what is diffuse. Let's talk about the first type, that is limited. So limited can be classified under two types, not two types, can be explained easily with the thing called crest, CRES. So limited symptoms of scleroderma can be referred to as crest. Crest is calcinosis, the calcium deposit on the skin. Reynolds phenomenon, again we see this Reynolds phenomenon in SLE as well. So Reynolds phenomenon is a spasm of blood vessels, response to cold or stress. Esophageal dysfunction. Your esophageal, this valve, it's a physiological valve. There is not any anatomical valve. So this physiological valve stops working. So dysfunction causes acid reflux, can causes a lot of fibrosis, because fibrosis can happen due to this healing. So fibrosis of the wall, right, and just decreased motility of the esophagus. Okay. Other thing that can happen is that sclerodactylity, sclerodactyly. Okay, thickening of tightening, basically of scleroderma. Okay, loose any wrinkles. You will see it's like no wrinkles here. Okay, we have the thing that's called as telangiectasis. Okay, my pronunciation of these terms are really bad. Telangiectasis. Okay, so dilation of capillaries around the node, right, around this part, causing red marks on the surface of the skin. Basically, dilation of capillaries, right? So that was scleroderma, right? But of a very limited type, right? And this is crest. C, calcinosis. R, Raynaud's. E, esophageal dysfunction. S stands for scleroderma. T is for the telangiectasis. I don't know, telangiectasis. Okay, like that. Okay, basically just dilation of the capillaries. Okay, what's the diffuse type of scleroderma? What are the clinical presentation? How do we recognize diagnosis? The diffuse means it's diffuse. It's like everywhere. It's not just at hands, right? So diffuse is like early visceral organs are involved: vessels, GI tract, lungs, heart, kidneys. And basically, it's a scleroderma of the renal, and scleroderma of the kidneys leads to renal crisis. The person can die. Esophagus is mostly affected. See solid and liquid dysphagia. Diagnosis is made by ANA. Again, autoimmune. This is seen in most autoimmune disorders. ANA and anti-DNA topoisomerase. Okay, it means. Okay, my pronunciation is really sucky today. I don't know why, because I'm sick a little bit. So what happens is that there's anti-DNA topoisomerase 1 antibodies, aka SCL70 antibodies. Now SCL here stands for scleroderma. So we have these specific anti-DNA topoisomerase 1. Okay, so we see this in diffuse scleroderma. So in limited, we see crest on the hands, right? In diffuse, the visceral organs are involved. Okay, what is the localized type of scleroderma? What are the clinical presentation? The crest is the clinical presentation. We already know that. Diagnosis of the crest of the localized scleroderma is made by anti-centromere antibodies, right? Okay. So when we talk about these antibodies called anti-DNA topoisomerase 1 and anti-centromere antibody, let's talk about, we understand what is antibody, right? Antibodies are directed against our own components, right? Nuclear, cytoplasm, membrane, etc. Blah, blah, blah. These are the markers of certain antibodies, right? These are the markers of certain autoimmune diseases, right? Okay. So when we talk about this anti-nuclear antibodies called ANA, anti-nuclear antibodies, this is an umbrella term. It covers a lot of things. So most of these antibodies called anti-centromere, anti-double-stranded DNA, anti-SLC70, they are part of ANA, right? They are the part of this umbrella term, and they get detected, right? And they are the markers. Okay, now let's try to understand each. So anti-centromere, this antibody targets something called a centromere. I hope you understand what is centromere. Centromere is a chromosomal region, and it connects the chromatids. Okay, it connects the chromatids. Now what happens that this is seen in crest, anti-centromere, and this anti-DNA topoisomerase 1, SCL70. Now the target of this antibody is DNA topoisomerase enzyme. Now this DNA topoisomerase enzyme, this actually is involved in the DNA unwinding. Now what happens is that DNA opens up, right? It unwinds. Now this enzyme is needed for the DNA unwinding, right? And if you have this sort of this systemic diffuse scleroderma, you will have this wide skin thickening, right? So the concept is that these anti-SCL70, these are very severe and diffuse, aggressive form of this antibody, and they stop the unwinding of DNA. So that's the concept. Again, another thing here is that in SLE we see something called an anti-dsna, that is double-stranded DNA. Again, the target is our native double-stranded DNA, right? And we see this in SLE, right? So I hope we understand this. So this dsna, this anti-dsDNA, this attacks our lungs, this attacks our kidneys, and really you can have renal crisis. Here I've written something called as anti-SM. Anti-SM means anti-Smith antibodies. Now these are small nuclear ribonucleoproteins, right? And the concept is that they are very specific but not sensitive. Okay, if this thing is present in your serum, it means it confirms SLE. It's a confirmation for SLE, anti-Smith antibodies. Other thing that we just read about is anti-RNP, ribonucleoprotein. Now we see this in mixed connective tissue diseases, okay, the overlapping, right? And concept is that there's like overlap features of SLE plus scleroderma plus polymyositis. Okay, we'll talk about this mixed connective tissue disease here. So mixed connective tissue disease, severe pulmonary hypertension happens here. Now, what is this mixed shit? Well, it's an autoimmune disease, mixed features of SLE, scleroderma, and polymyositis, right? Autoimmune damage of proximal muscles. Think patient with a bunch of autoimmune condition made by the presence of antibodies against human ribonucleoprotein. Okay, so that's the concept, right? So anti-RNA polymerase 3 is also seen. Now this is also seen in diffuse type of scleroderma. Concept is again this anti-RNA polymerase 3 can attack our renal system. Renal crisis will happen and then you can probably die. So that's the concept. So to sum up this whole concept about the disorders of autoimmune, I want to make a table, and let's make the table right here because I think this space is enough. So let's sum up. So to sum up this whole chapter, we have anti-centromere antibodies that seen in CREST, the limited type of scleroderma, anti-SCL70 that's seen in diffuse type of scleroderma, anti-double-stranded DNA seen in SLE, anti-Smith seen in SLE, anti-RNP antibodies seen in mixed type of connective tissue disorders, MCTD, anti-RNA polymerase 3 seen in, again, limited type of scleroderma seen in CREST, anti-SSA and SSB seen in Jorgen syndrome, causes neonatal lupus, causes photosensitivity, heart blocks, right? So that was the whole chapter about autoimmune disorders.